as a keynote speaker, famous for her talks on Botox and fillers in Asians, as well as integrative treatments and cosmetic surgery. She's a founding member of the Thai Association of Dermatologic Surgery, and we're so pleased to have you here as one of our chairs. So I'd like to go ahead and hand the stage over to our chairs, who will then introduce the rest of the speakers. But before we do that, I just wanted to take one last moment and thank also, it takes quite a village to make these meetings happen and successful. And Dr. Monica Surana, Dr. Arunda Abrol, current fellows with the Aesthetic Clinic, as well as Dr. Aishwarya Herlikar, who are integral in putting this meeting on. Want to thank Swami Touch, the tech partner, Riacon, our marketing partner, and of course, QR678, which is the main financial sponsor for this event that is allowing this to occur. So with that, I'd like to hand it over to Dr. Gorin and Dr. Suachinda. Thank you very much.
Well, thank you for inviting me, and welcome everybody for this lecture series. I think this is a very fascinating and great program that they put together today, starting with the pathophysiology of hair loss, talking about the different options and new therapeutics that are on the market today, what's coming. Some of the talks are going to touch a little bit about surgery and the different options available to our patients and what we see in the future. I'd say I've been in the hair field. I'm a professor of dermatology and visiting professor also at several universities. And over the years, the people who are dealing with hair are kind of a sideline of dermatology, and they were not like the most important part. And I think we've seen big changes in the last few years. I think probably in the last 5 years especially, there's been a tremendous amount of interest from pharmaceutical companies and from new research, obviously funding in androgenetic alopecia, especially also in alopecia areata, we see things. So the field is changing rapidly with a lot of new innovations, both medical, surgical, and even cosmetic side. So I think this would be very exciting for all of you to hear the latest and greatest from around the world. Thank you again.
Yeah, I can agree more to you, Dr. Gorin. I think we are going to have a very interesting session for today. And I also can't wait to hear your talk. You're an inventor. You know, it's nice to hear from the real inventor to see, you know, what's new that you bring to us today. So I think we should start now, so we have more time to our speakers, and then we have more time to discuss for today. So we first start with pathophysiology of the AGA recent findings presented by Dr. Monica Surana. Let me introduce her. She's a cranial maxillofacial surgeon, a fellow of facial plastic surgery and cosmetic surgery. She has keen interest in surgical and non-surgical modality to treat patients pertaining maxillofacial and cosmetic interests. She has won various accolades and prizes for paper presentation and poster presentation at various national, international conference. She is youngest speaker as for the 5th annual national conference organized in Bangalore in November last year, and she's life member of Association of Oral and Maxillofacial Surgeon of India and resident member of American Academy of Cosmetic Surgery. And she, of course, a national international speaker at various conferences. So she will talking about the recent finding in pathophysiology of the AGA. So please welcome Monica. Hello. Dr. Surana, I think you're not moving. It could be an internet.
Yeah. Maybe we want to switch the speakers, go to the next one first and just.
Yeah, that's a good idea.
Yeah, maybe would you please introduce our second speakers?
Yeah, so I'll be honored to introduce Dr. Arunda Abrol, who is a dermatology and virology specialist. She is a diploma at the National Board, and she's going training with different people in the field for cosmetic procedures. She's going to talk a little bit today about the latest non-surgical therapies in AGA. So I'm pretty interested to hear about that, both on the drug side, which I'm quite involved in. Maybe she'll talk a little bit more about what's available as non-drug, because it seems to gain a lot of popularity with patients. So welcome.
Thank you. Thank you so much for the introduction, sir. I'll just go ahead and share my screen. All right, is my screen visible?
Yes.
Yeah.
Yeah, it's good.
So,
it's all good.
Hi, everyone. I am Dr. Arundha. I'm going to be speaking today on the latest non-surgical therapies in androgenetic alopecia. So AGA, we all know, is one of the most common causes of alopecia in both men and women, and is characterized by a non-scarring progressive miniaturization of the hair follicles with a pattern distributions in predisposed men and women. It has a significant negative impact on the quality of life of the affected persons. And in contrast to the high prevalence of AGA that we see, the approved therapeutic options available are quite limited. So this is what we're going to be discussing today. There are a number of treatment modalities available for the treatment of AGA, with which the choice of treatment would depend on the efficacy of the treatments, the practicality, and the risks and the costs involved. Now, whatever modality of treatment we may go for, whether it is medical management or surgical or lasers or mesotherapy, etc., before embarking on any kind of treatment, the counseling of the patient, first of all, forms an essential aspect of the treatment. So the patients have to be made aware of the variable rate of progression of the disease. There may be some patients who will be who will reach the Norwood grade 7 in about 5 years, and there may be some who stay at stage 3 for 50 years. So depending on that, the currently available therapies have to be discussed with individual patients. They have to be made aware of the requirement of the maintenance therapy that would be required for a sustained effect. And also they have to be explained about the relatively slow improvement that might be seen if they go for medical management. And then again, for patients who would like to go for surgical mode of treatment, that we have to make sure that they come in for the treatment with realistic expectations. So when it comes to the medical therapies, the pharmacological agents that are used may be broadly categorized into either androgen-dependent agents or androgen-independent agents. So among the androgen-dependent agents, the 5-alpha reductase inhibitors, finasteride, we know, is so far the only US FDA approved oral medication for the treatment of male androgenetic alopecia. So it is a potent and selective antagonist of 5-alpha reductase type 2 enzyme. So it inhibits the conversion of testosterone to DHT, and thus it helps in reversing the miniaturization of the hair follicles, and that thus helps in encouraging the terminal hair growth. Now, it has been shown that it causes more prominent effect on the vertex regions as compared to the frontal hairline, and better results are seen in younger patients as compared to older patients. The oral dosage of 1 mg per day is the recommended dose for male androgenetic alopecia. Now, it is generally a well-tolerated drug. However, the sexual adverse effects associated with its use are well known and documented. Most commonly, reduced libido and erectile dysfunction that may be seen are usually transient and mostly resolve on cessation of the drug. Now, with long-term usage of the drug, the concerns regarding the increased risk of prostate cancer have come up. However, recent studies have shown that finasteride use long-term also is not associated with increased risk. However, it does cause an increase in the levels of PSA, which masks the symptom of prostate cancer. So in these patients, especially in patients who have a positive family history of prostate adenocarcinoma, it is mandatory to check for the levels of PSA prior to starting the treatment and then monitor it annually. Then in rare cases, gynecomastia or male breast cancer may be seen as adverse effects. Now, there is no documented hepatotoxicity or nephrotoxicity associated with its use. However, because it is metabolized in the liver, its use should be avoided, preferably in patients with liver diseases. Now, the use of finasteride in women is limited. That would be one, due to its limited efficacy, and also due to the teratogenic effects that it may have on a male fetus. It does have proposed benefit in premenopausal female AGA subjects, especially those with associated hyperandrogenism. And the usage of finasteride in women with childbearing potential should be done with caution, with strict birth control methods used alongside. Then dutasteride is a potential alternative to finasteride with increased efficacy, as it blocks both type 1 and type 2 5-alpha reductase enzymes. The dosage would be 2.5 mg daily in male patients and 0.5 mg daily in cases of female pattern hair loss, which has to be used for a minimum of at least 6 months. Now, the sexual adverse effects seen with dutasteride, like impotence, decreased libido, breast tenderness, etc., are reported to be more common as compared to those seen with finasteride. And again, monitoring of liver function would be required in patients using dutasteride. Now, there have been also attempts to use topical 5-alpha reductase inhibitors. So topical finasteride 0.05% gel and 0.1% lotion have shown efficacy in increasing the terminal hair growth. However, again, the evidence is still lacking. Then dutasteride mesotherapy has also shown good results in inducing hair growth in patients with AGA. Now, estrogen and other anti-androgenic treatments have a particular utility in female subjects, especially those with androgen excess or hormonal dysregulation. However, again, there is limited evidence to support their efficacy. Spironolactone, which is the most commonly used off-label anti-androgen for female pattern hair loss, is a potassium-sparing diuretic, and it is a structural antagonist of aldosterone. Given under dosage of 50 to 200 mg daily for at least 6 months. It is associated with side effects like postural hypotension and electrolyte imbalance. Now, cyproterone acetate, again, it directly blocks the androgen receptors and also decreases the testosterone levels by suppressing LH and FSH release. And it can be used either alone or in combination with ethinyl estradiol. Side effects like depressed mood changes or liver toxicity may be seen with its use. Flutamide is an option, a pharmacological agent that offers long-term stability in female subjects with AGA, and it has shown improvement in hair growth after only 6 months of treatment. It is a blocker of the androgen receptors, given at a dosage of 250 mg daily. The dose-dependent hepatic toxicity is an associated side effect, so the monitoring of liver functions should be done regularly. Now, there have been also several clinical trials involving the use of these topical hormonal agents. However, these are not FDA approved and still require further evidence regarding their efficacy and safety. So alpha estradiol is a 17-alpha estradiol. 0.025% lotion has been shown to increase the hair growth and cause improvement in patients with AGA. Then fluoridyl 2% solution, which acts by dissolving in the sebum and causing local blockage of the androgen receptors in the hair follicles. And fulvestrant is a pure estrogen receptor antagonist. 70 mg per ml twice daily has shown results in some randomized control trials. Minoxidil, we all know, is something we all use day in and day out. It is a first and so far the only topical product that has been FDA approved for the treatment of AGA. The exact mechanism of the drug on hair growth is still unclear, but it is probably mediated via potassium channel opening, which leads to an increased cutaneous blood circulation and enhanced levels of vascular endothelial growth factor and the hair growth promoting molecules in the dermal papilla. Then it is also suggested that it may promote hair growth by increasing the production of PGE2. The most commonly seen adverse effects with minoxidil are contact dermatitis and facial hypertrichosis. Now, the allergic reactions associated with its use are mostly due to the ingredients of the vehicle, particularly propylene glycol. And because true allergic reactions to minoxidil itself are quite rare. So in these cases, using a foam formulation is an option to avoid these adverse effects. Then hypertrichosis is reported more frequently in women than in men. However, it is still not clear whether it is actually an increased incident or it is just more noticeable in women. But it usually resolves 1 to 3 months after discontinuing the drug. Then again, counseling becomes a very important part. The patients have to be explained that there may be a transitory increase in hair shedding, which is seen at the beginning of the treatment in some patients, but usually lasts for a few weeks. The mode of application also has to be explained. So it is recommended to apply 1 ml twice daily to a dry scalp, preferably with a dropper. In cases of foam formulation, half a cap twice a day would be the recommended dosage. Now, the topical solution should be left in place for at least 4 hours. And the therapy has to be continued for at least 6 months prior to assessing its efficacy. And the patients have to be explained that on discontinuation of the treatment, there will be clinical regression to the previous stage of balding that was there within the 6 months. The use of minoxidil should be avoided in pregnant females. However, its use in lactating females has been approved by the American Academy of Pediatrics. Then again, combination treatment of topical minoxidil with oral finasteride, OCPs, with other topical agents like tretinoin, azelaic acid, ketoconazole shampoo, etc. Can be done. Then prostaglandin analogs. So in patients who were being treated for glaucoma, topical PGF2 analogs like latanoprost and bimatoprost resulted in elongation and pigmentation of the eyelashes and the eyebrows. So it basically acts by prolongation of the anagen phase, which results in new hair growth. So there have been studies showing its effect in treatment of AGA. In a randomized double-blind placebo-controlled trial, the use of latanoprost 0.1% has showed a significant increase in the hair density as compared to baseline and placebo without any significant adverse effects. Then bimatoprost has also been studied for the treatment of AGA in both men and women, and there are currently clinical trials in progress regarding its efficacy and safety. Ketoconazole has anti-inflammatory properties, but it also has anti-androgenic properties as it can interfere with the steroidogenesis. So its use in combination with oral finasteride might produce an additional decrease in the scalp DHT levels. So a possible beneficial anti-androgenic effect of ketoconazole 2% in women with female androgenetic alopecia and associated hyperandrogenism has been reported. However, again, larger and placebo-controlled studies are required to clarify its efficacy and safety as a co-adjuvant treatment. Then topical melatonin 0.1% solution has also been shown to increase the anagen phase of the hair in males and female androgenetic alopecia with good tolerability. Now, apart from these well-established and documented pharmacological agents, there are a number of miscellaneous agents that are being used today that are available OTC and have shown good results in treatment of AGA. So there are agents like adenosine, amino acids, caffeine, ginkgo biloba, ginseng, melatonin, and retinoids, etc. These have been shown to promote the hair regrowth by inducing the anagen hair phase. Then again, aminexil and botulinum toxin type A have also shown good results in treatment of AGA, and studies are currently ongoing. They have been suggested to improve the hair growth by increasing the perifollicular vascularization. Then certain topical agents which act by inhibiting the 5-alpha reductase enzyme and reducing the local DHT activity like saw palmetto and green tea are also beneficial in AGA. Then oral supplements, biotin, topical niacin derivatives are required for the improvement of hair follicle nutrition and energy. Then apart from the medical line, low-level laser therapy is the only FDA-cleared device to treat AGA. So red beam or near-infrared non-thermal lasers are used at a wavelength of 600 to 1000 nanometers. Now, the exact mechanism of hair growth stimulation by using this is not known, but it is believed that it accelerates mitosis and stimulates the follicle stem cells and alters the cellular metabolism and causes an increase in hair growth. So low-level laser therapy, laser combs, laser helmets, etc. have demonstrated notable improvement in hair density in patients with AGA. Then minimally invasive treatments like mesotherapy, microneedling, PRP, etc. are also in use. So mesotherapy is basically the intradermal infusion of a blend of components in diluted doses. Various molecules are available which can be used via mesotherapy to cause increase in hair growth like minoxidil, finasteride, growth factors, biotin, etc. QR is one such molecule, which is a revolutionary treatment for alopecia. It is a unique mixture of growth factors that can be administered locally into the scalp and causes increase in terminal hair growth and has shown very good results in male and female pattern baldness. Microneedling by using derma rollers, electric pens, etc. Also helps in improvement of hair growth by promoting the controlled tissue injury, and it can also help in drug delivery via microchannels. Carboxytherapy is again, it induces an increase in the blood flow, and the improvement in hair growth is seen. However, the clinical evidence regarding its use is still lacking. PRP, there have been some studies showing beneficial results in the treatment of AGA. However, there is no fixed validated protocol, no standardization, and is a cumbersome procedure. In patients who are severe grades of alopecia or who do not achieve desirable treatment with these lines of medical treatment, cosmetic aids like camouflage techniques can be used, for example, micropigmentation, fibers, scalp spray thickeners, etc. Then hair extensions and wigs are also an option, but they may be associated with traction alopecia and irritant dermatitis. And apart from that, hats, scarves, bandanas, etc. can also be used to achieve thickening, a visible thickening of the hair. So this was regarding the medical treatment. The surgical line of treatments is going to be discussed in the previous talks, in the coming talks. Thank you so much for your patient hearing.
Thank you. Something is wrong with my camera. Oh, sorry. Thank you very much for this. This was, I think, a good overview of a lot of the topics that are on a lot of our minds. I would like to say, though, a couple of things that I've heard that I know that a lot of lectures lately in Congress have been talking about this topical finasteride, and it's not necessarily a new concept. I've heard this in lectures probably 7, 8 years ago, but it goes counterintuitive to the fact that what finasteride is. Finasteride is actually an analog to the steroids that you use, and steroids are actually inherently porous through the skin. And so when you apply that to the skin, it goes straight to your bloodstream. It doesn't stay there on the head like people think that you apply it topically. By going to the bloodstream, the only way that it has an effect is actually have to be at the serum level, has to be equivalent to the oral. So to get to that same steady state, yeah, it will have the effect, but you're not reducing what you would think will be the adverse events. Now, the adverse events are a whole different topic. And I can tell you, I've seen many patients. I have a case, it's a real case, that the patient was given finasteride 1 milligram daily. I run into him at a restaurant maybe 3 months later. I ask him, how's it going? How's the drug, whatever. And he's like, oh, I stopped taking it. I had horrible libido problem, erectile dysfunction. I asked him how many doses you take. 1 pill he took. So that goes to tell you. And, you know, I have many friends who are urologists who would tell you that the 5 milligram finasteride, you know, at a year, and there's many studies that show that at 1 year or even 3-4 months after using 5 milligrams, just 5 times the dose daily, there are no more adverse events of what's expected in the placebo group. It's about the same. So whether there are some, you know, post-finasteride syndrome or not, I don't know. I'm not a psychologist to explain that, but I do know that that you would expect the same adverse events from a topical one. Now, compound to that, I would be extremely worried, and this is my message to the topical finasteride group, is applying it in males even if it was ever approved in males, as what is the effect on females. So when they actually develop the testosterone gel, the T-gel that you apply and rub on your shoulder, one of the things that the FDA required the companies to make that is to see how it transferred to a female partner. And so they did some experiment, and I don't know what the experiment is, but they defined it as vigorous rubbing for like a few minutes. And so when the female vigorously rubbed, there was a huge spike of testosterone in her blood. Well, I expect the same to be in finasteride. Again, it's a steroid analog. It is going to go straight to your skin. So if a woman rubbed my hair and I have this thing on my head, how much of it is going to transfer to her? I see some significant shortcoming to that approach that I personally have an issue with that with patients. So, and I think another interesting topics you touched on, I just wanted to make up a point, is on the minoxidil, which is actually the area of my group is research most probably, and probably one of the only groups still researching minoxidil. We strongly believe that the vascularization is not really how minoxidil works. So we published a paper about how it most likely increases the number of mitochondria in those cells, but it's not necessarily vascularization, because if you look at, and there's plenty of studies to show that there's plenty of blood flow in patients that have AGA. If you actually measure the amount of blood flow in the scalp through laser Doppler, you can see that there's no difference between AGA and non-AGA patients, or between bold and unbold regions within patients. So it's hard to believe that that will be the mechanism of action. There is something that happens while it gets sulfonated inside the cells of minoxidil to the active moiety, the minoxidil sulfate. But how does that drive hair growth? We don't exactly know. That is a true statement. Anyway, very interesting topic. A lot of great things to discuss from her. So let's go ahead to our next speaker.
We can probably discuss more of this in the panel discussion. So I did have a couple of points to bring up. Let's do that in the panel discussion.
Perfect. Let's go ahead.
Over to Monica, I guess she's back. Monica, you're on mute.
Sorry for the internet mishap.
Okay, go ahead.
Yeah.
Who is introducing Monica?
I was already introduced, sir.
Okay, you were introduced, I guess, yeah.
Yeah. All right. So good evening, everybody. I'm Dr. Monica Surana, and today I'll be speaking on pathophysiology of androgenetic alopecia, the recent findings. So we all know the hair growth cycle. It has basically three phases. That is anagen, which is the growth phase, and then the catagen phase comes, which is a transition phase, and then the telogen phase, which is a resting phase, where the hair bulb detaches and it dies. So androgenetic alopecia is the commonest cause of alopecia amongst others. And the recent understanding of pathophysiology has improved over the last decade, which has paved way for better diagnostic and therapeutic options. So in the famous painting in Vincent Van Gogh has depicted that even the baldness can be entitled to depression and partly attributed to psychosocial problems. So also it has been mentioned in Shakespeare's era, where the only option for those affected was to live with it other than using wigs for cosmetic purposes. So now, as we have evolved, we have a deeper understanding of the genetics, molecular basis, and pathophysiology of androgenetic alopecia, which has paved way for effective treatment modalities on the basis of these understandings. So the importance of understanding and treating this condition is growing because of the emphasis that modern society lays on looking good. So this was a phenomenal paper that was conducted by the aesthetic clinics, which is basically the iceberg phenomena of alopecia associated with the public ramifications on the quality of life among adults in India. So this has significant results, which has shown that what we all know about hair loss and its associated psychosocial problems is just the tip of the iceberg. Beneath that, there are a lot of psychological effects such as loss of confidence, loss of self-esteem, social phobias, psychological effects such as stress, anxiety, distress, depression, and suicidal tendencies as well. So what this concludes, this paper concluded was, in a nutshell, was that what is not on the head can affect what is inside the head. So in men, the prevalence is highest in Caucasians, according to the studies. In Indian context, a population-based study gave a prevalence rate of 58% AGA in the males aged 30 to 50 years. And the commonest pattern was type 2 and type 3, according to Norwood Hamilton scale. In women, it is more around the 19% in Caucasians, and the incidence increases along with the age. So the pathways we know so far are hormonal influences, hair follicular miniaturization, genetics, and environmental factors. The pathogenesis of regarding the hair follicular miniaturization basically is diffuse hair thinning and increased hair shedding, which precedes the clinical appearance of baldness by a number of years. The process of follicular miniaturization does not simultaneously affect all follicles within a unit. Instead, there is a hierarchy where initially the secondary follicles are affected initially, and then the primary follicles are miniaturized. So it is characterized by stepwise miniaturization of the hair follicle, resulting from alteration in the hair cycle, leading to vellus transformation of the terminal hair, in sense going backwards. The histology of the follicles in androgenetic alopecia also shows that there is miniaturization in the secondary follicles, leading to the reduction in hair density that precedes the visible baldness. Baldness only gets visible when all the hairs within a follicular unit are miniaturized. So the hormonal influence is basically, in females, it is the decreased aromatase activity, which leads to elevated local concentration of testosterone that seems to be operating in female pattern hair loss. Whereas in males, the elevated activity of 5-alpha reductase enzyme, which basically converts the testosterone into dihydrotestosterone, in predisposed genetical individuals, the follicles over the temporal and the vertical regions are most affected. So what are the new horizons in the pathogenesis of AGA? The recent findings includes the role of erector pili muscle, WNT beta-catenin pathway, follicular microinflammation, prostaglandin imbalance, loss of extracellular matrix, and oxidative stress. So the role of erector pili muscle is a new finding, and it has a great implication for the androgenetic alopecia. According to one study conducted by Rodney Sinclair, a 3D reconstruction of the scalp biopsy was done, where the preservation of the erector pili muscle predicted reversible hair loss. Conversely, the loss of attachment between the erector pili muscle and the hair follicle bulge was associated with irreversible or partially reversible hair loss. So the APM, or the erector pili muscle unit, plays a significant role in maintaining hair follicle integrity. The restoration of the APM in transplanted hair follicle units has shown to induce the regeneration of the neurofollicular and neuromuscular junctions in the follicle bulge in single follicular unit transplants in patients with AGA. So the hypothesis that maintenance of the attachment between the APM and the bulge might differentiate between the reversible and irreversible hair follicle miniaturization. These features were exclusively seen with regards to AGA and were not seen either in alopecia areata or even in telogen effluent. So in this diagram, we can see that the red part, which is the erector pili muscle, is still attached to the hair follicle bulb in telogen effluent and areata, whereas in androgenetic alopecia, there is the replacement, progressive replacement of the erector pili muscle by the adipose tissue, and hence it loses its attachment. There were other studies which have focused on the role of erector pili muscle and its role in hair loss and androgenetic alopecia. Now, coming on to other modes, the WNT beta-catenin pathway, it's basically essential for hair follicle development, hair cycling, and hair growth. It is the first trigger that stimulates the dermal papilla cells, resulting in induction and initiation of hair follicle formation. The reduction of the cytoplasmic or the total beta-catenin protein is induced by the upregulation of glycogen synthase, which is ultimately induced by the androgens. Activation of this stimulates the hair follicle and results in androgenetic alopecia formation. The prostaglandin imbalance basically is due to the increased expression of prostaglandin D2, which is reported in the scalp of men with androgenetic alopecia. The increased levels of prostaglandin D2 temporarily are related with the initiation of miniaturization of hair follicles. It also inhibits hair growth, whereas the prostaglandin E2 has a reverse effect or a growth promoting effect. So the imbalance between the D2 and E2 seems to contribute to hair loss in AGA. The follicular microinflammation is now a well-established and recognized factor which plays a pathogenic role in early phases of AGA. There is mild to moderate lymphohistiocytic inflammation around the peri-infundibular region of hair follicles in patients with AGA. The potential triggers could be antigens such as Propionibacterium bacterium species or Malassezia species. So basically, it can have a plausible role and which can result in the activation of collagenases, especially matrix metalloproteinase, and may lead to complete destruction of hair follicles. Coming on to the last pathway, that is the oxidative stress, it is basically the DNA damage due to heat shock protein, which could be induced by either the mediators of smoking or ultraviolet light induced exacerbation of AGA. The loss of extracellular matrix is related to the naturally occurring tetrapeptide, which is a potent angiogenic factor, which has an upregulation for the synthesis of epidermal keratins and also collagen 3. So this is in general nutshell of all the 5 pathways. Here we can see that the pathways, microinflammation, WNT pathway, direct stimulation, all are mentioned, and the therapeutics related to each pathway have been mentioned in the green box. The newer therapies based on the understanding of recent pathophysiology of AGA could be summarized as, so for the pathway of hormone antagonists and hormone response modulators, we have topical 5-alpha reductase inhibition, oral 5-alpha reductase inhibition through dutasteride and finasteride, botanical inhibitors and oral anti-androgens and estrogens for female pattern hair loss. Coming on to the pathways where the therapeutics work through the WNT beta-catenin activation, we have topical valproic acid, hair stimulating complexes, and also QR678 neo, which works through this pathway. Prostaglandin based therapies are basically prostaglandin and prostamide analogs. The direct stimulation of the stem cells and dermal papilla cells include marine protein supplements, QR678 neo, which works on the different stages of the hair cycle and even the hair bulb. Microneedling, the newer factors such as clascoterone and even exosomes derived dermal papilla cells. The stimulation of extracellular matrix could be induced by tetrapeptides or digonoside. The other modalities, other potential future modalities based on these pathophysiologies are officinalis plant extracts, which enhances the microvascular supply of dermal papilla cell, topical roxithromycin, and other roles which are being studied to be effective for AGA are nitric oxide gel, vitamin D3, and nestin and noggin pathways. Thank you for patient hearing.
Hello, thank you, Monica. Thank you for a very informative lectures. I think we have a question for you at the end. In the meantime, I think we have our next speaker who has we talk about a very interesting subject. I would like to know more. I'm very curious about the QR678 neo. What is a new role in AGA? So our next speaker is Dr. Rinki Kapoor. She's a fellow of National Skin Center from Singapore, also the fellow at Stanford University in US. And without a doubt, she's one of the best dermatologists in India. And she has trained internationally in South Korea, in Bangkok, in US, and she also trained in cosmetic dermatology worldwide. And she has credential and accreditation from a top institute in the world, years and years of experience under her belt, which makes her one of the most sought after dermatologists in Mumbai. And she is a cosmetologist as well as is associated with some of the best dermatology hospital in India. And she will talk on the QR67 Neo, a role in AGA. Interesting, what's it today and the future. So please welcome Dr. Kapoor.
Hi, thank you, Dr. Achima. And very nice to see you here today. I'm so glad that such luminaries and stalwarts are there in this forum today. So thank you so much for the introduction. I'd like Dr. Monica, if you could please play my recorded presentation, because I had sent her the recording as I wasn't sure of my availability. So Monica, can you please go ahead?
Sure, ma'am. Just a second. Yeah. Hello.
Monica, try again. And if the video doesn't work, we may have to go to the next. Oh, here we
No,
go.
sir. This started.
Okay.
Hi, friends. Great to be back at Hair Talks again. The topic of discussion today is androgenetic alopecia, and I'll be discussing about a new modality of therapy called as the QR678 Neo, which is for the medical management of androgenetic alopecia. As physicians across the world are gaining more and more experience with this therapy, and patients all over the world are getting benefits of this wonderful therapy, what I believe is that this is probably the next revolution in medical hair care. QR678 Neo has been invented by the aesthetic clinics, and it has a United States patent and an Indian patent, and is in commercial production and available in multiple countries across the world currently. Hair loss, we all know, is a big problem, and androgenetic alopecia is probably one of the commonest reasons for alopecia. But it's not just a cosmetic concern anymore, and it's becoming a mental health problem, which is very well evident from this particular study, which was presented and published by the aesthetic clinics in dermatological reviews, which mentions that alopecia follows an iceberg phenomenon. That basically means that just like the tip of the iceberg that's above the water and the majority of the iceberg is under the water, similarly, the cosmetic problems that patients come with, for example, hair loss and other issues with alopecia, is just the tip of the iceberg. And the actual problem, which is the psychosocial impact of alopecia, is much more huge. And that's the part of the iceberg that's under the water. More so, the problem is more complex nowadays because a lot of youngsters are getting this issue now, and they started getting this as early as they're 15 or their 20s. In their early 20s, they started getting androgenetic alopecia. That's a big concern, and it's a big blow to their confidence and their socio-economic status. We all know that there are different treatments available for treating androgenetic alopecia, which ranges from medical therapy, that's drugs, minoxidil, oral finasteride, surgical options like transplants, lasers, non-invasive therapies like pre-RP, stem cells, etc., and so on and so forth. But we all know that there is no universally effective therapy for alopecia, and each of them have some of the other issues with them, for which could range from unpredictability of results, side effects, lack of enough peer-reviewed evidence, especially in treatments like PRP and stem cells, not enough data that's available. The cost might be very high, especially for surgical procedures, and patient acceptability and compliance is also a problem with procedures which are very long in duration. So to overcome the barriers and challenges and uncertainties with the existing modalities of therapy, the QR678 was born. Now, this came about almost in the year 2010, with, of course, preceding this were many years of clinical research that went into bringing the solution to life. And since then, it's been used for treating different types of alopecia, not just AGA, but also other forms of alopecia like areata and post-hair transplant cases and telogen effluvium, etc. So what is this QR678 Neo? It's basically a unique mixture of specific growth factors that are meant for hair growth in the right composition after years and years of research, and is delivered at the target area, that is the hair bulb. It's got a US patent, an Indian patent, is FDA approved as well, and it's been found to deliver better results compared to PRP, stem cells, etc., which are the current modalities of therapy, which we'll see in the next couple of slides, where I'll show you the publications with this particular invention. So how it's available is that it's a sterile 5 ml vial, which is there, which has a rubber and a metal seal, and one vial can be used for about 5 sessions because it's 1 ml per session of administration. Now, what is the QR678 formulation? What is it that's there in this composition that makes it unique? What is it that's there in this composition which helps it to work in so many different causes of alopecia, especially androgenetic alopecia? And that's the composition here for you. It contains 6 basic hair growth factors, lots of vitamins, essential vitamins, minerals, and amino acids as well. So the growth factors being the VEGF, the BFGF, IGF-1, copper tripeptide, KGF-1, thymosin beta-4, and of course the all other ingredients, that's vitamins, minerals, and amino acids. And this is the particular mechanism of action. So for any therapy to work successfully in androgenetic alopecia, there are a couple of things that the treatment should be able to do. So one is stimulation of anagen phase, then prolongation of anagen phase, increase in the blood supply to the root of the hair follicle, working on the hormonal component, which is there, especially in androgenetic alopecia, and also working on the inflammatory component. So we all know now that AGA has a chronic inflammatory element to it. So the treatment must also target the inflammation that is there. So that's the reason precisely. And this is what, so every growth factor that's there in this composition has a specific role to play, and that's what has been seen here. So if you see the bottles of the QR here, you see it on the hair shaft, so it strengthens the hair shaft. Those yellow boxes that you can see at the hair root are the hormone receptors where the QR works as well, and specifically the copper tripeptide is the one that is important for this particular function. Then it stimulates the blood supply to the bulb or to the root of the hair follicle, which you can see in the catagen phase. Then you go to the telogen, it starts stimulating the bulge region, that's a stem cell rich area, the bulge region of the hair follicle, to stimulate anagen. And once the anagen is stimulated, it keeps the hair follicle in anagen for a prolonged period of time. So that's precisely the reason it's working at different stages of the hair cycle, and that's why it can work effectively in AGA and many other cases of hair loss. So it's cost effective, much more effective than a transplant, much more beneficial and effective than a PRP, for example. It's a non-surgical procedure, it's plant derived, so it has 0 side effects. I just like to show you how the treatment is administered.
A very good day, everyone. I'm here today to demonstrate the administration of the QR678 hair growth factor formulation using the mesotherapy technique. Now, it is a quick, simple procedure involving the use of a few basic materials like a pair of gloves, BD insulin syringe, some alcohol swabs, and of course the QR678 solution. This is the box containing the QR678 vial. Now the growth factor solution comes in a 5 ml sterile vial. The vial has a removable plastic cap over it. So once we remove the cap, underneath that is the metal seal, and inside the metal seal covering the mouth of the glass bottle is a protective rubber bunk. Now using an insulin syringe, we draw 1 ml of the solution into the syringe. Now the dosage of the sessions is 1 ml per session, so each 5 ml vial suffices for about 5 therapy sessions. Once this is done, we seal the rest of the vial by placing a micropore tape piece over the flip cap, and the vial is then stored in the door of the refrigerator. Now, using the alcohol swab, the scalp skin is cleaned thoroughly before beginning with the procedure. Approximately 1 ml solution is injected into the scalp skin at each session. On an average, 60 to 70 tiny intradermal injections are administered, covering the visible areas of hair thinning and alopecia. The solution is injected through the Nappage technique using the insulin syringe. Each injection, as you can see, is given approximately 1 centimeter apart with a volume of 0.02 ml per injection.
So you see, it's a very simple procedure. It's basically a lunchtime procedure, and it's really, really simple, very economical on the time of the physician, the time of the patient. The patient just walks in, gets the treatment done. There's no anesthetic that's required, and there's no pain. And it takes about 5 to 10 minutes per session, and then the patient just walks out and comes back again after 3 to 4 weeks for his next session. So now this is the thing that we are looking at. This is what we're waiting for. So that's in front of all of you. These are a couple of studies which have been published with this therapy, and the first one was the first in man pilot clinical study that was published in Journal of Cosmetic and Laser Therapy, wherein 1000 patients with androgenetic alopecia who had not responded to traditional lines of therapy for a year were considered for this treatment, and the solution was injected into the scalp once in 3 weeks for about 8 to 10 sessions. And the objective and subjective assessments were done. The hair pull test showed that the hair pull test got negative after about 4 sessions. And the video microscopy showed an improvement in the number of vellus hair, increase in terminal hairs, and increase in the hair shaft diameter. Thereafter, we studied it, compared it with the existing modalities of therapy like the PRP. This was again published in the JCD. And we all know how the PRP works and what is the principle behind it. However, if you look at the study, you'll see a lot of difference and much, much better results. In fact, 3 times better results with the QR678 versus the PRP. And these are some of the pictures there. QR working much better. And even after cessation of therapy, a couple of months down the line, also the results are maintained as against the PRP that you can see here. So basically, this just to tabulate some of the differences between the two therapies. The QR is basically a standardized method of injection, frequency, preparation, etc. Whereas the PRP, despite it being around for more than 15 years, is still not a standardized procedure. And there's a lot of inter and intra-patient variation. All the studies that you see with the PRP that have been done, the review of literature, will show you that there's a lot of inter-patient variation, obviously, because every patient will have a different concentration of platelets in their blood. That's the first thing. So obviously the results are going to differ with every individual, and even the same individual, every session of PRP, the concentration of platelets is bound to differ. So that's a huge, huge problem with this therapy. The second is not enough data on the efficacy and safety of the PRP vis-a-vis the QR678, where there's a lot of data that's available. The QR is 3 times more efficacious. We've seen the study just before the slide. And there are hair specific growth factors only in the QR as against the PRP, where you have, it's basically a jack of all trades, master of none, because they're putting it in the skin, they're putting it in the hair, they're putting it in the joints and dentals and whatnot. So it's not a very hair specific therapy. Beneficial results with the QR seen in different types of alopecia as against the PRP, with not enough valid evidence is there. There's another thing wherein there have been found to be inhibitory growth factors in the PRP, basically the transferrin growth factor beta, which is there, and the epidermal growth factor have now been found to be biological switches. So they are stimulatory in some phases of the cycle, hair cycle, and inhibitory in some phases of the hair cycle. So some inhibitory component does exist in the PRP, which is not the case with the QR678. Of course, there is no investment in devices. There's no biohazard with the QR as against the PRP, where you have to invest in the devices, the centrifuge, and there's contact with body fluids, etc. Negligible side effects with the QR678. We've never seen any patient who's got a side effect with the QR678 as against the PRP, which is actually really painful. And of course, last but not the least, the QR is a patented and an FDA approved therapy for hair growth as against the PRP, which is still not FDA approved for hair growth. Now, that's what we've seen in the study, so I won't say this again. We've also done some studies with the derma roller with the QR678, because this was specifically done during the COVID times, because there were a group of patients who couldn't come to the clinics for the intradermal injections. So we tried to see if the derma roller administration of the QR is also effective, and it was found to be effective. However, there was some difference between the results of the two. However, it was also a very convenient technique to do, especially when patients cannot come to the clinic for the session. This is the phase 4 clinical trial, which is already complete. It's been done throughout the Asia Pacific, and multiple centers were there in this, and thousands of patients have been treated to prove the efficacy of the therapy. We also have a study with the QR678 in females who've got androgenetic alopecia associated with polycystic ovarian disease. And the results are here for everybody to see. Much better results after a couple of sessions of the QR678. This is female pattern alopecia, androgenetic alopecia associated with PCOS. Of course, if there's an underlying hormonal component, then that needs to be treated as well. These are some of the pictures that I'd like to show you, the before and after pictures in androgenetic male as well as in female. We also have tried it with higher grades of androgenetic alopecia, wherein we've combined it with minoxidil and oral finasteride and seen what is the difference. So a group with QR678 alone, and the next group with the combination therapy. So the combination therapy shows much better results in higher grades of androgenetic alopecia. And of course, QR678 in post-hair transplant cases, wherein the after a transplant, if you do not maintain the natural hair which is in between the transplanted hair, then that continues to fall, and then the results start getting worse. So if you introduce the QR678 a couple of months after the transplant, we get very good results because the normal hair is maintained. And this is, of course, the future of the QR678, wherein we've got this entire armamentarium that's going to come up. It's not yet available. So hair boosters and serums and shampoos, these will, of course, all be intellectual property. They'll be patented to aid the QR678 in its action. And we are also looking at a topical formulation so that the injectable is completely out, but that's going to take a good amount of time. And this is just to show you the patents that are available. And these are the various countries. Very proud to mention that it's an invention which is done in India and is being exported throughout the world, and is treating patients, more and more patients, and getting their satisfaction and appreciation globally. This is the social media channels that we have. Anybody who wants to give the benefit of this particular amazing, easy, effective, and convenient therapy to their patients can always contact us on the above address. Thank you so much.
Thank you for this talk. I guess I had one quick question before we continue. The next speaker is, what is the active ingredient of this QR? Hello?
Hello. Hello.
Yes. Could you hear me?
Yeah, Dr. Gorain. So
My question was, what is the active pharmaceutical ingredient in it? What's the API?
So these are basically the growth factors that were shown to you, the 6 growth factors which are there in combination. That is basically what is working, and which includes the insulin-like growth factor 1. Then you have the basic fibroblast growth factor, copper tripeptide, thymosin beta 4, and the keratinocyte growth factor. So these are the main components which work in their individual capacity to give.
But are they being delivered as a drug that they're trying to approve, or?
See, basically, currently, it's not considered a drug. It's not considered a drug. It's basically a cosmetic. So in India and the European Union, these biomimetic peptides, which are there, they're considered as cosmetic. It's not considered as a drug. So that's how it is there currently in this part of the world.
Okay, I understand.
Should we start with the next speaker then?
Any other questions? Anything we can move ahead? Can you hear me?
Yes, sir.
Yes. So I think the next speaker we have is Dr. Michael Gold from the United States. Is that correct on this list?
Yes.
Okay. Is Michael there?
So he is not here, but I have his recorded presentation with me.
Oh,
so
okay.
I can share that.
So Michael, first of all, doesn't require probably a lot of introduction. He's a dear colleague, a friend for many years, extremely active in everything to do with cosmetic dermatology and aesthetic dermatology. I've worked with him personally on many projects. He was the president and founder of many congresses, including DAZO, the 5cc, Scale Music City, and he's very well known worldwide, both in lectures he's done, clinical trials leading to FDA approvals for the various drugs and devices. And so I don't think he needs more introduction with that. And he's also editor of several journals, including the Journal of Cosmetic Dermatology. So please go ahead.
Hi, everybody. This is Dr. Michael Gold, and I want to welcome you to the International Academy of Facial and Cosmetic Surgery in association with the Global Cosmetic Surgery Group on March 6th. Wonderful group. Glad to be part of this virtually. Androgenetic alopecia now and the future. My talk is on recent advances in hair loss solutions. These are my academic appointments. I am the editor-in-chief of the Journal of Cosmetic Surgery, Cosmetic Dermatology, and the editor-in-chief of Dermatologic Reviews. I will have talk about some of the companies that I listed here during this presentation. So the global market for hair restoration is very big, and we all know that, and depending on which statistics and which groups you look at, there's millions and millions of people that have these problems. And people are looking to have surgical, non-surgical ways to address this. And the nice part for us in 2022 is we have wonderful solutions that we can give our patients, many of which you're learning at this symposium. Obviously, hair plays an important role in identity, self-perception, and psychological functioning. Hair loss can be devastating, a devastating experience for the patient. It can decrease self-esteem and feelings of personal attractiveness while also leading to depression and anxiety. Again, we have wonderful solutions both in the non-surgical and the surgical hair loss world, which you are learning today. Again, it is when you look at some of the statistics out there, hair loss and hair thinning is some of the most common age-related issues that exist. And 88% of men worry that that they can become less attractive and they're not as confident about their appearance when they have hair loss. Again, and that is true as well for women. So I want to introduce you to just a few of the therapies and treatments that we offer here in the US and that I offer in my clinic. This is a hairline called Virtue Flourish, developed at Duke University Science Group, and then working through a new company that I am happy to say that I do work with. It is a complete line of hair-related skincare products called Flourish. And again, what it works with is different types of packaging and different kinds of products, all related to this alpha keratin 60Ku clinical protein that has been found. Two groundbreaking keratin proteins that power Flourish, alpha keratin and gamma keratin. Alpha keratin is a large spring-shaped protein that nourishes the microbiome, repairs damage, and reinforces the strength of your hair. And gamma keratin is a small globular protein that provides hair with elasticity and flexibility, helping to reduce breakage and fallout. Together, this complex allows us or has the ability to repair and nourish the scalp, providing fragile hair with strength, elasticity, and flexibility that it needs to survive. So as top of whatever else we do, this is a great take-home product for our patients. It gives scalp fertility, fiber survival, and again, makes the hair look better. It can be used for androgenetic alopecia, telogen effluvium, post-pregnancy hair loss, and post-chemotherapy hair loss as well. We do have lots of other options in the non-surgical hair restoration world currently, and we have to keep this in mind. Only minoxidil and finasteride are the only US FDA-approved medications for the treatment of hair loss. There are other things that we all do on a regular basis, and you have to realize and keep in mind and make sure your patients understand that these are all off-label according to the FDA. But again, because of the fact that they work and that we can use them in our clinics, we are allowed to do that. There are several things that are coming. A wonderful review that I like to share with people. Cutis is a journal here that we have in dermatology, and in 2019 was a wonderful review of all the medical and non-surgical treatments for hair loss. So if you need a reference, I would take a photo of this paper and go see what it's all about, because it's a very nice review as for everything. I do want to bring up a novel topical androgen receptor inhibitor that's going through clinical research right now. Clascoterone is the active ingredient in a cream. We call it Winlevi here in the US. It's an androgen receptor inhibitor, FDA approved for the topical treatment of acne in people aged 12 years and older. It is not approved for the treatment of androgenetic alopecia at this time. The active ingredient is clascoterone solution, and it has gone through, as you see here, several trials. There's been a phase 2 clinical trial in males and females with androgenetic alopecia, looking at a higher concentration of the solution versus what we have already available in the cream. It's a different vehicle in the solution than the cream, and the studies have shown a potential AGA treatment effect with a more than 5% solution. Again, it is a different molecule, different mechanism than we have already, where finasteride has an anti-androgen effect on the follicle by inhibiting 5-alpha reductase. Minoxidil shows a vasodilator effect. And clascoterone antagonizes DHT's negative effects on dermal papilla by competing with the DHT at the androgen receptor. It reduces hair miniaturization and reduces dermal inflammation. Again, I don't want to spend a lot of time going through the studies. I'll just mention some of the things here. You can see a 6-month result on the right. There was a phase 2 dosing range study in males. There's a planned phase 3 clinical trial about to take place. There has been a 12-month dosing study. Again, when we look at this 12-month randomized double-blind vehicle-controlled study, this is how we do clinical work. Randomized to look at 1-to-1 to 1-to-1 to 1, double-blind versus vehicle, 404 patients. And again, patients receive different concentrations of the solution along with vehicle twice daily. Looking at primary endpoints, change from baseline in non-vellus hairs, the hair growth assessment score at 12 months, and total hair counts as well. So again, this was done, you see here, 6 sites in Germany. Again, and when you look at all of this, as far as results, you see the 7.5% did really well. And that was nice. Proportion of patients here who had favorable growth in their hair assessments, again, showed that at every level that we looked at, or they looked at, hair growth assessment was good. Clinically, you see hair growth, which maintained out to the end of the study. So adverse events, nothing of any significance. And so 7.5 was the candidate that is moving ahead for their phase 3 work. There are some other studies that have been ongoing as well. Females with androgenetic alopecia, again, a 6-month study that was performed in Germany. Again, 5%, 7.5%, and versus minoxidil and vehicle. Again, looking at similar things. This is a proof, again, another proof of concept that has been presented already. Looking at this in a multi-center phase 2 study. Again, 141 patients screened, 95 enrolled, looking at hair counts and everything that they did. Both the active treatment groups had directionally larger changes from baseline compared to vehicle. But again, it was not significantly different. But again, it showed that the clascoterone worked better in the treatment groups compared to vehicle, and over time, the proportion of subjects who rated hair growth as favorable was high, with both the active and the minoxidil compared to vehicle. Again, very nice treatment results. So again, we've got lots of interesting data here. And again, how we bring this to the United States and to the rest of the world is still being figured out, but we're looking forward to doing phase 3 trials in the US very soon. I do want to mention low-level laser therapy as another treatment. This has been around, again, for a long time, and we know that red light works for hair. But this is an interesting device known as Revian Red. Basically, there's lots of data out there with red light. And instead of using just 660 nanometers, this is a 660, but also orange at 620 nanometers to accelerate and renew hair and the hair growth. What I also like about this from the home device world is that it's a smart device. It uses your phone and work all the functions of the device, as well as keep the data and keep the information on how to use it and the appropriate way to use it and to remind people to use it and so forth. So I think that's important too. It works through the release of nitric oxide. This is Rodney Sinclair did a large study looking at this versus a sham device, found a 26.3 hairs per centimeter squared growth. So again, more than the red light alone in this study, but overall really nice results, as you can see in the clinical photographs here. More clinical work as well here. So again, red light works, red and orange seems to work a little better for this. I want to end by talking about a laser treatment using a thulium laser, 1927. This category has become very popular as a fractional device that can deliver actives to the skin, and this is from Lutronic. And what they've been able to incorporate here is taking this device, which again is a 1927 laser, make some superficial changes into the skin, creating channels for us to be able to deliver an active. And in this case, they have proprietary biomimetic synthetic growth factors and skin proteins that have been developed all through nanoliposome delivery into the skin, which allows them to get into the skin. Again, you treat the scalp, you massage in the characters, and these are the kind of results that one can see. So not only do we get thickening, but we get more density of the scalp as well, hairs, and that's really important for our patients. It's been used in all different skin types, all different kinds of hair loss, with some very nice results here as well. So I think we have some wonderful treatment options out there and more coming. And so I hope this talk was able to give you some insight on what we use and how we think and what we're planning to do in the future. I want to thank everybody for allowing me to participate, and I hope everybody has a great conference. Thank you very much.
Thank you, Michael, for very innovative and novice treatment. That's very interesting. And I think we should move to our next speakers. Dr. Harshit Rampara. He will talk about the latest hair transplantation in AGA. He's a dermatologist. So he's a chief dermatologist and owner of Adiva Center for Skin and Hair at Lashkot since 20 years, which this center is at the heart of the city of Lashkot, Gujarat. His main interest is hair transplant surgery, of course. So until now, he has done over 2,500 hair transplantation surgery, and he get Best Innovation Award in HairCon 2018 for his paper, A New Innovation in Extraction Forceps and Suction Device. So he has innovation in implanter, innovation in slit making process, and difference of coronal and sagittal slit is advantage and disadvantage, including the 3 patent of instrument of Adiva implanter, Adiva multi-slit maker, and Adiva extraction forceps. And a few more are in pipeline. So I'm curious what he will give us knowledge and latest in hair transplantations in AGA in 2022. I hope that you have new innovations, something for a hair transplantations already. So please welcome Dr. Renpara. Hello. Yes.
Hello friends, today I will speak something about latest in hair transplant in androgenetic alopecia in year 2022. Now I will divide my topic in following headings, just like what is new in hairline design, what is new in anesthesia, what is new in extraction, what is new in graft storage, slit making, implantation, dressing and post-operative care. Now, starting from hairline device. At present, we are using Dr. Pathom Vana's laser assisted hairline device. This is the picture how we draw the hairline with this device. The latest thing is one new PNP hairline design device. It is available now commercially. And the best part is that we do not need to hold the device in our hand. It can be fixed on forehead, and after that we can draw the hairline, anterior hairline, posterior hairline, man's hairline, female hairline, beard design, etc. we can do. Now, what is new in anesthesia? Three things are there. One is nitrous oxide sedation. Another one is the one sublingual opioid derivative tablet. And third one is adding dexamethasone to our long-acting anesthetic agents. Now, this is the nitrous oxide sedation in, hair transplant surgery. This is the machine of nitrous oxide sedation. I have started oxygen and mask kept on patient's nose. Now we are starting nitrous oxide. We are reducing oxygen level and increasing nitrous oxide level. And patient feel conscious sedation with this nitrous oxide. And after 2 to 3 minutes, if I give local injection, patient won't feel anything. Another one is a sublingual opioid sulfentanyl tablet. This study was presented by Malcolm Paul in last ISHRS conference, and this tablet is recently approved by FDA to provide profound analgesia for 3 to 4 hours. Patients experience minimal discomfort during anesthetic injections after giving this sublingual tablet. Now, third one is adding dexamethasone to bupivacaine, and this study was presented by Miriam Seal in last ISHRS conference, in which she demonstrated that adding dexamethasone to bupivacaine extend the duration of regional block while potentially decreasing the facial edema. Now, what is new in extraction process? Three things are there. First one is Trivelin's Mamba device. Second one is Devro's device. And third one is a preview long hair transplant technique. In Trivelin's Mamba device, there is a combination of rotation, oscillation, and vibration movement of our punch, and it exactly mimics like the manual technique. This is the picture of Mamba device. Another one is WOW system by Dr. Devroy. And this is the picture of WOW system. It's a perfect balance between technology and human touch, wireless system. Then preview long hair transplant. It's a technique in which grafts from donor area need not to cut short, and grafts are placed in recipient site as long hair. And the results are highly encouraging, even though the operative time is slightly longer than usual FUE. And key point is preview of end result is presented before surgeon's eye at the time of surgery. Now, what is new in graft storage during hair transplant? Usually we use extracellular solutions which are isotonic. It should not be chilled. Normal saline, ringer lactate, human plasma or plasma light A. pH of plasma light A exactly mimic the intracellular pH. So I usually use the plasma light A. And the latest study by Behner, published in Forum September-October 2021, has changed all our protocols. And in this study, it shows that the graft stored in room temperature in plasma light, means 21 degrees centigrade, survives better than graft stored in cold plasma light. So nowadays we use plasma light at room temperature to store our grafts. And one new QR678 we use as a growth factor. Here I am adding QR678 to our stored graft. We have started since last 3-4 months, and we are looking for good results with QR678. Now, another concept is first come out will first go in. This is a specially designed plate at our center. We can keep 200 grafts in each hall, and by this plate we can reduce the graft out of body time. Now, what is new in slit making process? This is the Ediva multi-slit maker, and this is the video of this multi-slit maker. In one stroke, you can make 5 slits. You can do sagittal or coronal slits, and you can do crisscross pattern to increase the density. Now, what is new in implantation? First one is the no touch to root implantation, and another one are development of multiple graft implanters. 2 implanters are there, in root KNU, and second one is high capacity implanter with 3 needles. In this technique, the hair follicles are not touched on entire length from bulb to dermis. We can hold the grafts with forceps like this way, and this is the video how we can insert the graft without touching it. It's by courtesy of Dr. Anil Garg and Dr. Seema Garg. Another one is in-root KNU multi-implanter, in which there are 10 needles. We can insert 10 grafts at a time, and it saves the time of doctor in giving and taking. This is the video how it works. Insertion of grafts into the needles. And now surgeon is starting the implantation. And you can insert 10 grafts at a time. So you can increase the speed of your work. Another one is high capacity implanter with 3 needle. And here you can implant 3 grafts at a time. What is new in dressing and post-operative care? SurgiHeal Pro solutions. 2 steps, step 1 and step 2. Step 1 is used in intraoperative procedure. The active ingredient is hypochlorous. It's an antimicrobial wound irrigation and skin cleansing formula. And in step 2, 2 separate solutions. One is for recipient area and one is for donor area. It promotes wound healing and dissolve crust speedily. Thank you.
Well, thank you for this talk. This was great. And let me introduce our next speaker is Dr. Viral Desai, who is a plastic surgeon. He's also consultant and director of Sarla Hospital in Mumbai and has pioneered some techniques in hair implantation, faculty, various conferences, including IMCAS, Dermacon, and has covered many subjects, including Botox, fillers, hair transplantation, facelifts. Well, welcome you.
Hi, my name is Dr. Viral Desai, and I'm a practicing plastic surgeon. I have been doing hair transplants for over 20 years. I am the founder, pioneer, and medical director of DHI India, and we run many clinics all across India. Now, I was asked to speak about all the innovations or surgical innovations that are going to be happening and which could change the future. Well, it could be robotics, it could be something else. We don't know what is really going to happen in the future. But I can definitely talk about 2 innovations that we have done that has made our results better. They are very difficult to adopt in daily practice, but I hope after seeing my presentation, you will go and adopt what I'm going to teach you today. Manual extraction and IFHUT. Now, challenging is when FUE started, it had a steep learning curve, which would intimidate the physicians. Every patient is difficult or challenging is also that we understand. Similarly, when we start something new, like manual extraction, it's going to be difficult as compared to what we are used to, that is motor. So first acquire manual skills before going into motor. There are 2 forces applied when we are doing, of course, hair transplants, when we are trying to extract the follicles. Number 1 is the axial force, which is parallel to the grafts. And number 2 is the tangential force, which is the force applied to the rotation or oscillation of the punch, and of course it is the opposite direction of the graft. Now, of course, remember this shear distribution force. This is a force applied on the surface. Now, in a motor, there will be lot of rotation, oscillation, and heat creation, and hence the size of this shear distribution force will be larger, and the size of the hole on the scalp will be hence larger as compared to a manual where there will be a clean cut. So this is using a 1 mm motorized punch. These are the size of the holes. Because of rotation of the motor, the shear distribution force is much more and hence larger size as compared to the same size punch, which is a manual, that is a 1 mm punch. Okay, here you can see the stark difference. Now, if you have cleaner cut, smaller holes, the healing will be much faster as compared to these holes which are created by motor, by the same size punch. Of course, there's going to be skin deformation if your punches are blunt. So, and that's going to affect transactions. So there are 2 methods, as we know, manual and motor. And it's like, I would compare it to automatic car and a manual car. A manual car, though more difficult to drive and maneuver, gives you far more characteristics that you can handle, that you can control. The control is in the hand of the driver, and in case of hair transplanter surgeon, as compared to a motorized car or a automatic car, I mean, a motorized punch. So of course, advantage of manual is better control, tactile feedback, less root damage, faster donor healing because of less trauma and clean cut wounds and less shear distribution force. In a manual, you get a far better tactile feedback. So of course, there is a difference of resistance between the tissues, and this helps when it's a difficult case like a curved graft or splayed graft. Resistance of the hair follicle is different from the surrounding connective tissue. With the manual, you can actually feel it and you can maneuver your punch accordingly. When you're using a motor, you have lost all this feeling completely and the transaction rates increase. Heat torsion. With motorized punch, the punch may get dull. You will not feel hit and the machine still continues to use its forces to cut. With that, of course, and generally also with the motor, there's creation of a lot of heat, torsion, friction. All this will lead to damage of the grafts and the survival will go down. So of course, to minimize the root damage, to decrease vibration, to not to traumatize, not to burn grafts, not to create heat, manual extraction is better. Disadvantage, of course, it's easy to understand that fatigue, since it involves the surgeon to perform this procedure, fatigue. Second, of course, you cannot give this procedure to your technicians. It has to be done only by qualified surgeons, since it's manual extraction. So of course, you cannot delegate this. And of course, it's difficult if there are long grafts, there's a lot of fat like body hair or beard hair. And of course, there's very hard skin, which we come across in certain cases. Now, hand fatigue with the manual technique. This starts with the manual technique. You can get a lot of fatigue of the hand. Of course, so life of a manual surgeon is maybe shorter. He may require frequent breaks. You cannot do maybe more than 4 to 5 procedures in a week if you're doing manual day in and day out. But what matters is, of course, the quality of grafts and not the speed. Now, motor extraction. This we all know as hair transplant surgeons. We all have been using motors. So we all used to using motor extraction. It's less fatigue. It's, of course, a faster procedure. Because you're using motor to do the rotation of the hand oscillation movements. So, of course, there's less fatigue on you and, of course, on your team and, of course, on your hands. It's a quicker procedure because motor goes much faster, but at the same time, you're probably compromising on the quality of grafts as well as you're probably compromising on the survival of the grafts and hence the results. If you put 100 grafts, if less survive, the results are definitely going to be less. Disadvantages of motorized extraction: reduced feedback. We've discussed this in detail. Tip replacement, you will not know when the punch becomes dull and then be more transactions, less control. Cost can be more, and of course more healing, more bleeding, more itching, larger hole size because of more shear size. So graft quality, as we can compare in both, in manual the graft quality is very, very neat when you see under microscope as compared to grafts seen under motor. Now, hand movements, rotating. The punch is rotated in one direction, either 180 or 360 degrees or somewhere in between 200 270 degrees. This is normally done by motor. Oscillating, when you go to and fro, rotated clockwise, counterclockwise, combination of both, of course, and stabbing and coring. This is a motion which is only possible with manual extraction. This is a clean motion. It gives you very good control and quality of grafts. However, if you're not used to manual extraction, especially in the beginning, you can get more transaction with this motion. But if you master this, your speed is nearly as much as motorized extraction. So here we can see oscillating, rotating movement, which is used in manual extraction often, less transactions, easier to learn, versus stabbing, only done by experienced surgeon. And once you master stabbing, your wounds are clean cut. It is a much faster process as compared to the other process, which is rotation. So of course, advantages of motor: faster, less fatigue, less number of punches required, easier to learn. It is standardized and control. And of course, the advantages of manual: better control, better tactile feedback, less graft transactions, no heat damage, no shearing forces, arguably less transaction, like I said, and smaller diameter hole and faster healing of the donor area. When you're using motorized punches, you use 0.8 or even less, because you know when your punch is 0.8, your hole on the patient's head is going to be larger because of the shear force. But when you're using manual extraction, you're going to use slightly larger punch, which is 0.8, 0.9 or 1 mm, and still your hole size will be smaller on the surface because it's going to be a clean punch. So you please understand, in manual, you only need very, very sharp, thin walled punches, outer cutting edge, preferably not inner cutting edge, and that gives you great results. So going by the principle, respect every follicle, aim at 100% survival. We think manual surely fits in this criteria very well. And if you have curved grafts like this, like afro hair or splayed grafts, then manual extraction actually allows you to change the position of your hand and extract gently, gradually, and you can get better results, better graft survival, and less transactions. Now, of course, ending this, I am going to be talking about another topic of great interest. We've adopted this into our practice and we find very good results, and that is IFHUT. So talking about the endless journey of the hair follicle, you first cut, extract them, process them under microscope if you're doing FUT, in some cases in FUE, preserve them for some time, create recipient holes, and then place. Total time of the body is a few hours. How can we reduce this? And if we reduce this, will it make any difference to our results? So why use a four-stop flight when you can use a direct flight? Cut the grafts and extract and place them directly. So total time out of the body is 30 seconds, only 30 seconds. Factors affecting graft survival. We all know when we start hair transplant, we know improper storage, temperature variation, if it's too hot or very cold, defreeze, processing under the microscope, duration of the procedure matters. Do not let any procedure go over 6-7 hours, and definitely don't let the grafts be outside the body for more than 3 to 4 hours maximum. Every hour beyond that, and we know that if the grafts are outside for longer, they will not survive well, and improper handling. The solution to this too is instant follicular hair unit transplant, IFHUT. This has been published by Journal of Dermatology and Dermatological Surgery by us, by 3 authors. Thank you. And I thank my co-authors also for helping me in the study. So what are the principles basically? Extract the hair follicles one by one and implanting them immediately after extraction. The time period when the grafts stay outside the body is reduced to a few seconds to less than a minute. There is no processing, minimal handling. So we aim at better survival, better growth, denser growth, and hence better results significantly. It conforms to the principle of less is more. So even if you go a little slow, if you do smaller sessions, let the patient recover immediately and keep calling him for smaller sessions of maybe 3-4 hours. So there's no downtime. The patient can return to work immediately. It conforms to this principle of less is more. Advantage of going, there's absolutely minimal handling or no handling of the follicles. There is no processing, so there's no trauma of the roots, minimal time out of the skin. The graft is placed back into the body immediately. You remove it and you place it back within a few seconds. Hence, it goes back into the environment it is used to. So it's milieu interior. It doesn't stay in milieu in exterior. It goes back to the environment or the body where it's used to. So there's of course minimal dehydration and desiccation. If the grafts are outside for long, there could be dehydration. They may not be hydrated well. Hence, they could desiccate. There could be temperature variations. All this can affect the survival of the graft significantly. So hence, no 4-way flight. No need of complicated assistance, microscope, processing, etc. And you just place the grafts immediately. Positioning of the patient. Now, what are the challenges you face? Speed is a big problem. Achieving symmetry. When you're placing immediately, you have to be an experienced surgeon to know that you're placing equally on both sides. Counting of the hair and grafts. Accuracy of direction and angle so that it looks natural. Positioning of the patient to prevent fatigue, and of course the surgical team and assistants to prevent fatigue. So case study here, it was a grade 2 baldness, grade 2, grade 3 baldness. We were only working on the hairline, which had practically no hair. One side, we put the grafts directly. As we removed them, we put them, and other side, we took the grafts out, stored them for an hour or two, and then we placed them. Now, this is how the technique goes. This is how we do the technique. So we are using manual punches, as I said before, and we are stabbing here. The stab motion, of course, is with a lot of experience. So here the assistant, the patient changes position, the assistant removes the graft one by one, loads into implanter, and the surgeon is implanting the graft at the proper depth, direction, and angle into the recipient area or the bald areas one by one. So of course you can see positioning of the patient, positioning of the surgeon, positioning of assistant. Of course, there is another assistant who keeps counting the grafts and counting the hair so that symmetry is achieved. This is how we carry on IFHUT. This is immediately after the process. Now, where D is written is where we've directly implanted them without storing. We've removed from the back and immediately implanted them. That is where D is written. You can see 1 month after the procedure, there is faster growth and more growth on the side where we implanted immediately. 2 months after the procedure, same. 3 months, there is some growth now coming on the other side where we stored the grafts, what we do traditionally as compared to the other side. And 4 months of the procedure, definitely there's better density, slightly higher density and better growth as compared to the other side. And hence we know that the grafts grow faster and better. Case 2, also D is when we implanted them directly, equal number of hair and grafts. You can see there's better growth on that side as compared to the other side. Case 3, same. So results, the graft blasts into the anagen phase. Immediately there's early growth, evident in less than 6 months. And of course, more growth, better graft survival. And hence it has a steep learning curve for the surgeon, for the assistants. It may be difficult to do, but it definitely conforms with the principle that you can, this method can potentially change the future of hair transplant industry. If we master this, if we can speed it up, we can definitely get better results. So I think manual extraction and IFHUT are the future. I hope there are other things which match up to what it is. And again, going by the same principle, we respect every single hair follicle, aim for 100% survival. Thank you. Thank you, organizers, for inviting me to this wonderful meeting. Thank you so much.
Thank you. This was a wonderful talk. I know that I'm actually scheduled for the next set of slides, but to be honest with you, a lot of the lectures covered pretty much everything that I wanted to talk about. And I would like to suggest maybe we move to the discussion section where I can actually add a few questions and thoughts about a lot of these therapies, because I think most of you have heard about all these different modalities of treatment, from laser therapy to microneedling, and maybe instead of going to, again, a lot of these things that I think all my colleagues here have given, it would be better to go into a discussion.
Actually, from the panel also and from the delegates, there are a lot of questions for you, Dr. Gorin. So as a result of which, I think it would be a good idea to maybe just go through your presentation nonetheless. Possibly take a little bit less time if you so please, but people have been waiting to listen to you for a long period of time. So in the interest of all the delegates who've congregated to sort of listen to you, we request you to possibly take a few slides, and that would probably be helpful for everyone leading up to the panel discussion.
Okay, no problem. Do you have the slides, or do you need that for me to?
You can just share the screen and take it over from there.
Okay, let me just try to do that. Give me a second.
We have all the questions, dear chairpersons, mentioned on the chat, both here in on Zoom and as well as on WhatsApp as well. So we'll just wait for Dr. Gorin to complete, and then we'll move forwards.
Okay. Can you see the screen?
Yes.
Yes, we can. Yes, we can.
So I'll try to be brief, and then I have some more questions and to go over. I guess I start with the simplest thing, is the future of hair loss. So when we talk about future of hair loss, we really mean the future of hair growth. But I was asked to give a talk several times about future of hair loss. So we hope there's not going to be a future of a hair loss, but hair growth. But I don't really have much conflict to declare. I'm involved in certain capacity with all these different companies and sponsors and universities that I work with, and different researchers among them. So just for the sake of going into the past of hair loss, in the past we were very hairy. And those are how at least we think our ancestors were. Okay, it doesn't work. Hold on a second. There you go. And scientists believe primarily hair was for thermoregulation, And I don't think I need to get more into that, but the erector pili muscle that was mentioned earlier, which actually led to an innovation that we patented and actually is a commercial product, is really important in terms of regulation. We see that in other animals as well. There's also the idea that hair is important for touch transaction, where we know that neurons actually signal touch. This can be protective effect in animals like whiskers, for example, or eye protection. And of course, there's also social signaling, potential protection from UV radiation, from heat and cold. But through evolutionary adaptation, it looks like most of our hair has been gone over the years. And why did this happen? And let me know if I'm going a little too quick, but I'm trying to go quickly through this. Why did this evolutionary adaptation occur? We don't really know. One of them obviously seems a little more remote is about because of communications. I think that's a little bit more remote, but most likely it's because of what happened in Africa over the last tens of thousands of years, where the savanna was expanded, and through weather and changes in climate and geothermal effects. And so through this changes, there were temperature changes, there were a way how people started walking upright, there were hominoids, which eventually led us to losing hair. Since then, we obviously found in the present ways to regulate our climate, so we really don't need hair as much anymore. We have heating, we have air conditioning. So where are we today? So we were hairy before, and we really don't like body hair today. So when you see body hair today, for most of the people, they're like, oh, I want to remove my body hair. There's laser therapies for that. But then we like hair on the head. And when we actually lose hair on the head, it's a sign of aging, and it's not accepted, and it looks bizarre. However, when we shave our hair, it's sexy. So it's a little confusing. What do we actually want? We don't want body hair. We want hair on the head, but if we shave it, it looks good. So what is it that we really want? So from a purely evolutionary point of view, and this is a paper that I wrote several years ago with a group of my colleagues, we're really heading into full baldness. So in our future, maybe in the next 100 years, 200 years, human beings will be bald from evolutionary perspective. And one of the things that we saw, we did a survey a while ago. I don't remember when we published it. I know 2017, so maybe we did it in 16. We did a survey of several of our colleagues in dermatology, and 88% of them reported an increase in incidence of AGA in young men. And the title of our paper was really interesting because what we noticed, and this relates actually to the genetics of androgenetic alopecia, is that social selection might favor the offspring that are prone to AGA. And why am I saying that? So the phenotype, which is a bald man, and I'm talking right now primarily about males, are actually selected genetically by men who have a short CAG repeat polymorphism in the androgen receptor gene. And that's been demonstrated in several studies. My group has actually pioneered one of this whole thing in early 2000s. We have sequenced androgenetic alopecia patients. There are other groups around the globe that have done the same. And at the end, the conclusion is that, and I think it's well established fact now, is that androgenetic alopecia is genetically mediated. It's, at least it's necessary. It's not maybe sufficient for developing androgenetic alopecia, the genetics, but you need a genetic variation in there. There are different SNPs that people have looked at, but one of them is the polymorphism, the CAG repeat in the androgen receptor, which actually determines the transactivation domain of the androgen receptor. Well, interestingly enough, if you look, you inherit this androgen receptor from your mother, and then interestingly enough, if you look at females with the short CAG repeat, it actually predisposes that female to PCOS. So why is that related to why we're going to be fully bald? Because if you look at our social selection, women tend to have children at a later age nowadays. That is just an established fact. And what we see is that in women that are able to have children at a later age, they have a phenotype similar. They're more likely to have a phenotype that's similar to PCOS. So even though in the past it used to be thought that women with PCOS are unable to conceive or have very difficulty to conceive, well, what happens is they actually can conceive, but actually their ovarian reserve is viable to a later age. And so there was a paper that showed that the CAG repeat, the shorter one in the androgen receptor, actually predisposed women to have offsprings at a later age. Well, given the social pressure to women to actually marry and have children at a later age, those women are more likely, the ones that can actually give offspring at a later age, to give an offspring that will be bald. So all this theory at the end is that at the end, we're heading, and I think this summarizes this thing, we're heading to, just because of social pressure maybe, to men who are more bald in society. So this is very interesting theory, but I think you want to hear about the future of not going bald rather than going bald. I had a few interesting projects that I worked with. This one, I think people talked about various similar things with injections. So I'm going to skip the follicular unit regeneration, but it's in a way of how to induce stem cells. It's experimental. I've worked in different groups testing this, but I will skip this one. This is a clinical study I did for an innovative group out of Israel. They had the radiofrequency device for hair growth. So this is very, very similar to the microneedling effect, but it's through RF energy. So unlike microneedling that does cause pain, because we do need to get to at least 1 millimeter to cause any activity, this seems not to cause any pain. It also has hair growth stimulation, increase in hair width. Something happened to this. The slide is not showing properly. Okay. I will not go through all these things, but it's the same that you've seen in all the other devices that cause some sort of tissue remodeling by enhancing both the collagen, the circulation, growth factors. They have developed a unique proprietary system to deliver that. But what's interesting, what we have done is after 10 treatments, about 2 weeks between each treatments, you can see, okay, 31% increase in hair count. Let's see, the pictures are not showing up for some reason. Oh, there you go. So you can see this is in female pattern hair loss, 10 treatments. This is some examples. She dyed her hair a little differently, but you can definitely see the differences here of growth. So it's a very interesting thing. And this is a similar idea to all the microneedling that you see and some of the other products on the market. This is a project. The next one is a sulfotransferase booster that, and I think this is the right explanation here. So this is a project that I've worked at over the last 10 years. And my group actually was the first one to pioneer this. We isolated the enzyme that is responsible for minoxidil sulfonation or activation in the hair. So topical minoxidil, everybody knows already. We talked about it on the FDA drug approved for female pattern hair loss, the only FDA also topical for men. Unfortunately, the response is pretty low. So I'm sure as dermatologists you've seen, or plastic surgeons, many patients with that. I've personally probably seen about 10,000 pictures of patients and been involved in dozens of studies on minoxidil. Unfortunately, you know, the great response is probably 5% of these patients at best. Some responses, you know, you'll find somewhere between 30 and 40% of patients. There's a difference between patient-reported outcome, which was what you hear on the marketing, where 8 out of 10 patients report improvement or they see hair growth. Unfortunately, and this is something I've been advocating to a lot of my medical students and residents, is that when you look at the data, you should actually look at the clinical studies for the FDA. And what you see that the patient-reported outcome on the vehicle is also 5 out of 10 patients. So the delta between 5 out of 10 and 8 out of 10 is about 30%, which mimics what you'll see in the investigator report. Because if you look at the hair counts or you look at the investigator reports, you'll see that there's about 30 to 40% of patients actually will improve. This is with global photography. I know that many of the studies, and maybe I'm getting deeper into some of the other discussions, but many of the studies have focused for approval on a more concrete thing than a global photography, which is hair counts and change in hair counts. Unfortunately, if you look at data for many of the studies, there's no concordance between them. So While you might see hair count increase, you might not see improvement in global photography, which actually makes sense because why would you think that a 20% increase in hairs in a square centimeter and that spot on the head is going to be indicative of the entire scalp and the hair growth? It's been an area of controversy, actually, even in the regulatory side of things. Minoxidil was approved knowingly that there's no concordance between the hair counts and actually hair growth in global photography. Now, this is I think, a very important thing for anybody who's considering treatment, talking to patients or developing drugs, is that, or devices, is that we can talk all day about 20% increase, 30% increase, 15% increase, but it's irrelevant to our patients. The patients here are coming for an aesthetic cosmetic procedure or drug treatment. And the endpoint has to be the satisfaction when they look in the mirror or how they perceive themselves in society is really the endpoint. It's not that I can say, okay, well, I can document you increase by 20%, but it doesn't mean anything to me. When I look at the mirror, it didn't change anything to me, then the treatment failed. So this is a very important point that as much as, yes, we do have endpoints of hair counts that are important, far more important to me in any of these drug development and any of the treatment of any patients or any interaction we have with patients is to try to help them as clinicians to resolve their main problem, which is hair loss. They are not looking for a number to show that you have a count. So this is a key thing. So minoxidil in general, if you look at the number of responders, it's about 30 to 40%. We developed over the years minoxidil response test where you pluck a couple of hairs. It's actually commercially available. I'm not affiliated with that. We patented and licensed it, but I have no conflict of interest. So that's available in the United States. It's approved diagnostic test where you pluck a couple of hairs, you ship it to a lab. It's a CLIA approved lab. I'm sorry?
Sir, 2 minutes to
It's called minoxidil response test. It's I can send you the link later. You ship it to the lab and they will be able to tell you whether they responded or not responded to minoxidil. So the advantage of that is instead of taking 24 weeks or so or more to use a drug that may or might not work for you, you can actually find out if it works for you or not. And the positive predictive value or negative predictive value, it's exclusion test about 96, 97%. 97% here. And there's many papers we published on that with quite a few different of my colleagues in dermatology. I think we have close to 15, 20 papers on this device, and it was very interesting. So this led to a very interesting thing, and I'll just say in 1 second how the principle of this works. This lecture is not really about that. It's kind of an overview of things, but I have many other lectures I'm happy to forward to anybody. I have many lectures I can share about the mechanism of action of this, but the way the minoxidil response test works is pretty simple. So minoxidil is actually not an active ingredient. Minoxidil is inert in the body, it doesn't do anything. It's actually xenobiotic, and your body tries to eliminate it. So in order to actually eliminate it, it sulfonates it using a sulfotransferase enzyme. It's a xenobiotic metabolism phase 2 enzyme. The sulfotransferase, this is what my group identified as specific isoenzyme in the hair follicle, in the outer root sheath of hair follicles. So it's called SULT1A1. And so if you have low activity or low expression of the SULT1A1, and we found the thresholds for that through clinical studies, you're unlikely to respond to minoxidil. So so what we do is we pluck the hair because it's in the outer root sheath, and we can actually determine the activity. That's what this assay does, of the SULT1A1 in your outer root sheath. So if you have a certain, within 24 hours of the test, if you have a certain reactivity in the solution, it's an activity assay, we will know that you're a responder. And if you're below the threshold, you're not a responder. So we can tell you with 97% accuracy that minoxidil will not work for you. So this was determined through clinical trials. So that was very interesting for us over the years developing that. And it was very exciting to see that we can make some significant contribution to minoxidil. But and by the way, I would say this also just as a separate part to that is people will say, and I've seen people selling over the years, minoxidil sulfate, because they're saying, okay, well, I don't need minoxidil. If minoxidil is the active thing when you don't have sulfotransferase, why don't you put minoxidil sulfate? Well, great idea. So there's been some papers and suggestion minoxidil sulfate is not stable. I don't know if that's true or not true. It depends which formulation you have, but I can tell you that my group is able to make a minoxidil sulfate stable. That's not necessarily the problem. The problem is the minoxidil sulfate does not penetrate the cell to create the actions required to grow hair. And why is that? Because the entire mechanism of minoxidil sulfation occurs inside the cell using the sulfotransferase 1A1 enzyme. So minoxidil enters the cell, and the way it's excreted out is by sulfonation. It becomes more soluble. So the minoxidil sulfate is not actually going to enter into the cell. It's something that gets excreted out of the cell. So when you apply it topically, you get nothing. And most of these probably formulations where they have 10% minoxidil sulfate, yeah, they're adding 10% minoxidil because the sulfate part doesn't do anything. So just keep that in mind when you see. Yes.
I'm sorry to interrupt. We are just running out of time. Would you just wind up and maybe in a couple of minutes, because there are a few questions also for you from the audience. So we'll move on to the panel discussion after that.
Sure. So I'll just give the last piece to this. So the main question we had is what happens to the 60 to 70% of patients that don't respond to the minoxidil? So we found a way to actually upregulate the sulfotransferase 1A1 enzyme. We found out something to the hypoxia mechanism. It is an accidental discovery over the years that we have done. And that project, I don't know if there's, we've done several studies. One of the studies actually originally we did with Rachita Durat in India, and we've shown that we can upregulate sulfotransferase enzyme over 14 days of daily application of a shampoo. It can also be a solution. This is published paper. Then we have done several studies to actually show minoxidil plus placebo versus minoxidil plus we call it the booster in AGA patients, and then in responders and in non-responders. And we had some pretty, I don't see if there's a graph here, but we were able to double basically the amount of responders. So we were able to have 75% of patients increase hair growth compared to 33 on minoxidil, which is what you would expect. And this is published paper, so we have a statistical significant. You can see here some the minoxidil and the active booster in some patients. This was actually done originally with the group with LTM Cyan that I'm involved with. We had actually very good results, actually quicker too than just minoxidil, just within 60 days, which we do not expect usually. And this is versus the booster. You can see no change in those patients. So this is some example of that. There are other products that we developed. This is with the erector pili muscle. I won't get into that today, but I would just say briefly that excessive hair shedding, my colleague Rodney Sinclair worked on that. We did a big survey, and we shown that quite a few women, or 40 to 50% of women, claim that they have excessive hair shedding when they wash their hair. I developed in my group a topical cream that what it does is actually contracts the erector pili muscle, causes what's a goosebump, and we've shown that can reduce the hair shedding significantly. So we increase the force of pulling the hair. It's a whole subject of another lecture, by 180%, and we reduce on average 42% of hair shedding. We've had many papers on this too. And Senesca hair, I'm not going to get into today, but we are working on some melanocyte transplantation. So overall, I'll just say it's a very exciting field. We have a lot of advances, a lot of things to talk about. But even though our evolution is, I believe we're going to be bald eventually, all of us, just from evolutionary rate, I think that we're going to be hairier than ever in the short term. And this is my son who wants to be a dermatologist eventually. Thank you, everybody.
Thank you for a fabulous talk. Maybe we can move on to the panel discussion, everyone. So Dr. Achima, Dr. Andy, we've put the questions in the chat as well. So we've got the first question. That's all right. I will read the questions out. Thanks for logging in. And so the first question is for Dr. Gorin. It's from Dr. Tapasya from Patna in India. And what she asks is, why do dermatologists look at hair transplant as a panacea for early cases of AGA? It sounds like bypass surgery being advised for high cholesterol levels. Your take on that?
Why? I didn't get it. Why do dermatologists?
Why do dermatologists look at hair transplant as a recommended treatment for early cases of AGA? it sounds a bit to her like bypass surgery being advised for high cholesterol levels. So the
So
point
I
she's
don't think
trying to
that that's
make.
the case. I think that dermatologists in general are a little bit more conservative with that. I think in early stages of AGA, we do not want to do surgery because it often progresses. What we need to do is sort of like, treatment for vitiligo. We don't treat vitiligo until it's actually stable. We will do the same thing with AGA. I think younger patients, I know that a lot of younger patients are seeking hair surgery nowadays because people are getting bald maybe earlier, but the issue is that if it's progressive and it's not treated constantly with medication, it will actually get worse. The outcome will not be so positive. So I think the majority of physician would recommend either treatment with finasteride, even though it's become sort of a hot button to a lot of people and controversial because of this whole issue that people are complaining about post-finasteride syndrome. But that would be definitely something to recommend to patients if you feel comfortable recommending it, as well as minoxidil. And I think if the outcome is started early on, especially with finasteride, it does prevent hair loss significantly. If you see a progression at the later age, I would say, and when you get to close to your 40s, 35, 40, and you really it's more stable with the drugs and you really still feel that there's a hair loss and you want to fix it, then I think surgery is more appropriate. But I don't think it's the first line of treatment. It depends, of course, how much hair you lost when you went to the physician the first time. And definitely not for women. It's more on the men's side. That's the other issue.
Sure. Great points. This question is for Dr. Viral Desai. Viral, are you on?
Yeah, I'm here.
This is from Dr. Harshal in Mumbai. And his question is, do you prescribe medications after hair transplant on every patient? And does every patient need to take medicines after hair transplant?
Yes, I do think that post-operative minoxidil, we started typically after the 7th day, is important. And of course, multivitamins. When you're talking about minerals, you're talking about magnesium, zinc, calcium. There's a very interesting paper by Dr. Rajput, Cyclical Medicine in hair loss. And I think they work very well with hair transplant too. So that's important. And of course, if you are comfortable using finasteride, you should use finasteride. In cases which don't respond too good to finasteride, you can even try dutasteride. It's arguably got less side effects or more side effects. It's a very controversial topic. Some people say it has a lot of side effects. Some people say less side effects. But yes, both of them work well and they do help. We see better results with both of them. In many cases, I also prescribe laser helmet. LLLT is one of the oldest treatments being used for hair loss. It does give good growth, and sometimes, of course, PRP can help to boost up the growth.
Thanks, Viral.
Yeah, I have questions for Dr. Desai because that's the questions that I usually get from patients who've done hair transplantations, and then we have to put the patients on the oral medications. And then they ask, what is different if, they don't do hair transplantations and they take the oral medication instead? Because you also have to, take oral medications, the same thing.
It's they don't replace each other, because what medications do is delay the hair fall, decrease the hair loss, maybe help to thicken the diameter of the hair, which is early hair loss. They are not going to grow roots where you don't have roots. When there are no follicles, you have to do a transplant. There is no option. So in my 20 years of practice, I've seen patients who've been taking medicines for 5 years, 10 years, who are grade 5 and grade 6, who have absolutely no living root on their recipient areas. And they're just wasting their time and taking medications. So yes, hair transplant and treatment for hair loss, medications complement each other. They don't replace each other. So that's what it's important to understand.
Yeah. Yes.
The next question from the panel is for Dr. Achima. This is from Dr. Louis from Texas. His question is, do you believe that low-dose diode laser actually works? Seems like more like a placebo. So do you believe that it actually works? And do you use it in your practice?
Absolutely. I believe that it's work, and I also, use it in my practice, and it showed that I have a great result, in the monotherapy and also in combination with, other treatments. So I think it worked the same as you use a low level, laser for a wound healing. It's not only for the hair things, but we also use it in the wound healing treatment, or in the nerve regeneration, or even induce the pain. So it's basically it works, but it works in a different mechanism as we use the laser as in other treatments. It's not produce heat. It's actually a non-thermal effect. It low intensity, so it's give non-thermal effect, but basically it alter the biological activity in the cell. So basically it's kind of modulate it like photobiomodulation, or photo biostimulations, some kind of that. So it's even though you don't really have a precise mechanism how it works, but it has strong evidence that it acts on mitochondria. So it stimulates mitochondria, it leads to increase in reactive oxygen species, increase in ATP production. So it's benefit to the cells. So it's helpful for the cells. So it stimulates the anagen phase. So it's make it duration of anagen is a kind of prolonged. So it's helped to moderate the hair cycles, increase in hair density, and also decrease in hair shedding. I think the question is, there's so many of the products out in the market. After 10 years that it's approved by the FDA, that it has evidence that it helped in hair growth, then you have tons of the products in the market, and it's difficult to determine which one is really work better than another, or which one is actually not working at all, because there's so many factors that you have to look at, like which wavelength which actually the best, you still don't know. We have a range of the wavelength between 650 to 900 that it work, but we don't really know which actually working the best. And you have low-level lasers and diode lasers and LDD, and we still don't know which one work better, but most of the devices actually have combination of both. So it still have many things. I mean, it still have a lot of questions, which devices actually work better than the others.
Thank you, Dr. Achima.
I just want to say something curious
Sure.
about the blue light, red light. I've been approached by several companies to look at that, and some university research we've done. And I can tell you that I am very skeptical that it works as a monotherapy at all. There is not even a shred of evidence there is any receptor, any biological effect to red light at that level. There is actually a blue light receptor in the hair follicle. We don't know why, but none of these lights work in that frequency. There is a potential theory that when you combine it, for example, with minoxidil, you might improve the penetration of the active agent to the scalp. And so as a combination therapy with minoxidil, and there was some small study that was done at Cornell that showed that laser plus that is superior to just minoxidil. It was a very small study. But that I can see some mechanism of action potentially, because when you heat something, you have a potential of increase of absorption through the scalp. It does take minoxidil on the average 4 hours to have the majority, it's like 80% of it absorbed through your stratum corneum. That's why they tell you not to wash your hair for 4 hours after you apply it. So I think that, that there is some potential synergistic effect, but I don't know that by itself it has any effect, and there's no plausible mechanism of action also that shows that it would, but that's just my 2 cents.
I'm sure the combinations actually work better than the mono.
Thanks. The next question is for Dr. Rinki Kapoor. It's from Dr. Dominic from Paris. When would we do a hair transplant, and when would we do QR678? Do you have a protocol when you do it for, when you would prefer a hair transplant, or when you prefer QR678?
No, so that's very similar. I mean, Dr. Viral has answered some part of this already, but basically the early stages of hair transplant, the early stages of hair loss, alopecia, the medical part of therapy works really, really well. And transplant would probably an option if the patient is slightly elderly and he's got some areas of hair loss where there are no follicles. So there, obviously, you'll have to consider a transplant. But early stages of hair loss, younger patients, definitely you'll consider medical therapies like the QR678 without any question.
Thank you. The next question is again for Dr. Gorin. And this was actually to Dr. Michael Gold, but he's on an airplane at this moment. So we'll let Dr. Gorin as well as Dr. Achima respond to this, and anyone from the panel who wants to respond to this. So the question is from Dr. Veena from Bangalore. And the question is, are the new generation drugs a whole lot better than the earlier generation? That is dutasteride better? Is it a lot better than finasteride? Where do you see, a follow-up question is, where do you see hair treatments going in 2050? And will hair transplants be obsolete by then? So that's to Dr. Gorin and to the rest of the panel.
So I cannot comment on all new therapies because they're in the pipeline. So we don't know until we have the studies and we see, the results. But as far as dutasteride, it's really not a new therapy. It's been an existing benign prostatic hyperplasia treatment for a long time. Some patients report better outcomes than finasteride. Unfortunately, we will never really find out, on large scales whether it's superior or not, just due to the fact that financially, nobody has an incentive to spend money on a generic drug to find out if it's better than another generic drug. So I think that the answer is possibly it's better. It'll have the same adverse events either way, as far as the patients are concerned. I mean, I don't know that it's better than taking 2.5 milligram a day finasteride. I would guess probably not much difference in the long term. The inhibition of dutasteride of DHT is quite similar. It's a little bit bigger than finasteride, but it's dose dependent on finasteride too. So I don't know that it's a big deal. There are other agents. Dr. Gold shared with us a few anti-androgens that are being explored topically. As you can see in those photographs, it looks like minoxidil is still superior to that, and that's been a big challenge. I've guided several pharmaceutical companies over the years in developing drugs and even procedures. And the problem is that when we try to compare things to minoxidil, often, unfortunately, they don't provide a superior benefit. And we've seen that with the prostaglandins. There were several large studies that were funded by some significant pharmaceutical companies on prostaglandins, and they did not result in better outcome than minoxidil. They end up costing a lot of money for the product if it was ever commercial, but it was shelved because at the end of the day, the outcome was inferior to minoxidil. So I'm very optimistic that we'll have some improved treatments, but I think surgery is not going away. I think, in fact, we have to look at it as a continuous involvement of a disease, and it's like everything else. If we treat early, our chances, and it's everything in medicine is the same, our chances of great outcomes are great. So that's why I've always believed in early diagnostic, whether it's genetic markers, molecular markers, whatever you have, to find patients at risk. Not when they come to you as a doctor. We all know about 50% of the hair loss is lost in that spot. It's very hard to recover that. It's like anything else. Once you have diabetes, once you have heart disease, once you have all these, actually at that point, the treatment, it becomes more and more difficult. Just like end stage cancer, we do trials on these patients, very hard to recover them. But the early stages, most of it, like finasteride, can stop it. And I think we'll be getting better and better agents, less adverse events. I've been striving to work with a few groups to do a sustained release drugs that you can do just like Botox, inject them every several months and 3 or 6 months, and you don't have to worry about it, and you maintain your hair or regrow some hair. But I think regrowing from a completely bald scalp hair is going to be impossible. But I think that you're always going to have patients who will come with partially bald scalp who will need surgery. For that, I think we'll see innovation in the surgical space. I think there is going to be a way how to do follicular unit multiplication that will be better eventually. We will go through that. There will be ways how to maintain your hair better. So I think it's a combination of things. So it's not a binary decision. But I do think eventually we will get it right how to make better follicular unit multiplication. I think it's an extremely complicated way how to grow this organ. But there's a lot of interest in that, and I think eventually maybe people also be aware they need to do early treatment. I mean, I think there's no better treatment than early prevention, right?
Dr. Achima, what do you expect to be the standard of hair growth in 2050? And do you think we'll be able to guarantee a full head of hair to all people by then? Your comments as well. We are in the final 5 minutes, so we'll take comments from all the faculty on what seems to be an interesting question.
Well, for me, I agree with Dr. Goran that we have to diagnose early, and then we start the treatment early. And at the moment, we have, in my experience, I think we have such a effective, treatment at the moment. The combinations of everything that we have non-invasively. We can do it, we prevent it before the patients have to go for hair transplantations. However, hair transplantation is still keep for a patient who actually have severe hair loss. But the early stage of hair loss, we can help a lot of the patients. And I do a lot of PRP, and I think it's really helpful for the patient that PRP together with the light treatments. Some patients, particular type patients, some patient doesn't want to take oral medications. So even without oral medication, is still, effective. The only problem is the pain. So if we can, do it without pain, that would be
Dr. Rinki, over to you. Same question.
So yeah, actually, the right time to treat hair is yesterday, right? It's not today or it's not tomorrow, but it's yesterday. So the earlier you treat the patients, the better it is, and the more easier it is to treat. And I also believe that the very fact that there are so many therapies that are being devised, there are so many new therapies that are coming up, just points to the fact that we even now we don't have something which gives a really satisfactory result. So alopecia is a huge arena where there are a lot of possibilities, and I think there are a lot of things that are being devised newly, and hopefully they'll be carrying us to a situation where everybody will have a head full of hair. So it's going to be a combination, no doubt. It's going to be a combination of surgical and medical, and it's up to the physicians to decide the best for their patients. And I think we have definitely exciting therapies like what was discussed today in this session, and really look forward to something amazing.
Dr. Viral, your chance.
Yeah, we're talking about like 25, 30 years from now, and the way medical science is progressing, and especially in the field of hair, I'm sure that we can look at a lot of medical therapies, a lot of treatments, which will actually decrease and delay hair loss significantly. We'll be able to treat them, recognize them earlier, treat them so we prevent further hair loss. And transplants will never go because, at one time we could not do more than 1,500, 2,000 grafts in one session or in a day. And today we're managing to do even 4,000, 5,000. We're taking hair from all over the body. We're doing a lot of pubic hair, chest hair. So an average person who's grade 5, grade 6 requires averagely 9,000 to 12,000 or maybe 14,000 grafts to cover his head. And an average donor would give around 6,000 to 9,000 grafts. I'm talking about from the scalp. So now with the advent of body hair, beard hair, body hair from all over, we can increase these numbers significantly. So from transplant perspective, if you improve your graft survival, you do not waste a single hair follicle. Every follicle that you remove from anywhere in the body, you put it in the proper place, proper way, in the proper direction and angle, you're going to get great results. And of course, with newer therapies coming up medically, I'm sure that 2050 is going to be exciting. At least we'll have most of the people who are compliant to medical therapies with full head of hair, I'm sure.
Dr. Arunda, your thoughts?
Yes, so I guess everybody is pretty much covered. So I agree with all the interventions in the medical and the surgical therapies. Right now, I'm sure it's going to be the scope in the future is huge and immense. But also another thing that I think will change also is that people are now more aware. They come to us at an early time. The early diagnosis is also something that is going to lead to better results. So yeah.
Dr. Monica, you're muted, Monica.
So two things that being from a not a dermatologist background, but still in the facial plastics, I have in the last 1 year seen maybe n number of patients, and the patients we see nowadays, it's not just the index of 30 to 50. We see as early as 17 years in grade 4 or grade 5. And it's pretty much a lot of genetics which is playing around, but it is also the environmental factors and the foods which affect our hormones in such a way that we cannot control those factors. So I think any person living on this planet right now is suffering from hair fall. And as we have advanced in our strategies, it's like if you are there, you would have hair fall. And yes, the science has progressed that now we have gone into genetic level, and we are targeting gene therapies. So maybe there would be one day where would be just taking hair from, this is my thought. I always wonder that we would be asking our friends to just give the hair as a donor, just like a transplant in its truest sense, and we would be doing it on some other person.
Interesting indeed. Coming to the end of this, the final 2 or 3 minutes of these hair talks as well. Over to you, Tanuj.
Well, on behalf of the entire organizing group here with Global Cosmetic Surgery, just want to thank our esteemed faculty for providing such amazing knowledge to all of us and to all of the listeners around the world. And then, of course, not only is this live streamed, but people watch these series of lectures for months and years to come because it's stored on the Facebook channel. So thank you once again to all the faculty. Without you, we would not be able to have this meeting. It's been such a pleasure for me to listen to this broad spectrum of medical, surgical, epigenetic information on hair loss and treatments into the future, balanced with science, balanced with individual experiences. It's really been a fantastic session. So congratulations to the entire team and all the lecturers. We really appreciate your time.
Thank you, everyone.
Thank you again.
Thank you once again. And everyone stay safe and look forward to seeing you all again. Thank you so much.
Thank you.
Thanks,
Bye-bye.
Thank you. Thank you. Bye-bye.
We have one more comment, which is that we have a wonderful pipeline of additional series lectures that'll be coming from Global Cosmetic Surgery. On March 27th, we are excited to have a aesthetics masterclass on 5-minute pearls from the masters. We will be having lectures from around the world of esteemed surgeons in the entire area of facial cosmetic surgery. And so tune in on March 27th, and we will be sending details on social media channels.
Look forward to seeing you all then soon.